Good afternoon, ladies and gentlemen. My name is Justine Baqueta. I will chair this ERKNet webinar that will be presented by Professor Dieter Haffner from Hannover Medical School in Germany. And you may probably know Dieter, who is in charge of the CKD-MBD working group at the ESPN, chair of the guidelines at the IPNA Society, and involved in the bone metabolism and calcium and phosphate metabolism. And today the title of his talk is X-linked hypophosphatemic rickets, new clinical practice recommendations.
Justin, should I start? Hello?
Go ahead, Dieter.
Justin?
Yeah, go ahead.
Yeah, okay. So, yeah, okay.
Go.
Good afternoon, everybody. I'm happy that you all are present here, despite the fact that it's quite hot summer day, at least in Germany. And the topic is XLH. And as we remember, a few months ago, I already had a webinar on this topic. So today I will focus on the guidelines and not so much on pathophysiology things. First, my disclosures, and then a few words to the introduction. So it's about XLH, the most common cause of inherited phosphate wasting disorders. As far as we don't know really what is going on in XLH, but we know that it's characterized by elevated secretion of the phosphaturic hormone FGF23, which causes two things at the kidney. First, it inhibits the NAPID transporter, so you get phosphate wasting, and in addition, it impairs the synthesis of active vitamin D and increases the degradation of vitamin D, which in turn results in hypophosphatemia, vitamin D deficiency, and the clinical symptoms of rickets. What we usually do as poor clinicians, we substitute phosphate and give active vitamin D. This we did for many years. And now there's also a new treatment modality available in many countries. It's called burosumab, which is a fully humanized antibody against FGF23. And this will also be addressed in the guideline. So why did we do the guideline? There was no evidence guideline on this topic, and the ESPN launched this initiative in June 27, and this worked until 2018, so 1 year, and then we built up the recommendation. Then of course there was the review process in Nature Reviews, which also took almost half a year. And the good thing is that many European societies and reference networks for rare diseases endorsed the guideline, which is also basically due to the fact that many people working in those networks were also present as core group members in the guideline group. So it has been published just a few weeks ago, and it's published as open access. So if you don't understand things, you may ask me later on. But the best thing I would recommend, go there to the homepage of Nature Reviews and open it as an open access and read it. It's a long text, but we felt that it's worth to write it comprehensively because it's a tricky disease, and we felt a high responsibility, not just writing a brief recommendations, but also go into details, because it's not a simple disease, and we didn't want to oversimplify this tricky disease, to be honest, and for the sake of the patient's outcome. So we addressed many topics, including diagnosis, children as well as adults, workup, follow-up, treatment in children and adults, and also addressed comorbidities like orthopedic, dental, hearing, neurosurgical, lifestyle. We made conclusion, and we also formulated a lot of future questions to address in further research. So the guideline has, I think, 14 pages if you print it out. If I would show you all the slides, then we will stick here until tonight. So I will only address about half of the content. I will solely focus on children. I will talk a little bit of workup, and I will address only treatment in children. And for the comorbidities today, I will just focus on dental comorbidities. So let's start. With the methodology, we followed the right statement for practice guidelines and the grading system from the American Academy of Pediatrics because we thought it's helpful. We built up a core leadership group of 20 people. They included specialists from pediatric and adult endocrinology, pediatric nephrology, pediatric orthopedic surgery, rheumatology, dentistry, neurosurgery, and 3 patient representatives. So this was quite a nice group with a lot of discussions, and it was very helpful also for me to hear from other specialists, and together I think we made a great effort to work up this guideline. And I just want to mention that, of course, Justine Bachetta was also part of the core group. So we proposed recommendation after the meeting, and we used an electronic questionnaire and the Delphi method and an external voting group, which was independent of the core group, and we sent out their recommendations and they independently reviewed it. And if more than 70% of the people from the Delphi group were happy with the recommendation, we kept it. If they were not happy, the recommendation came back to the core group and we modified it. So we addressed first important questions, which we call PICO. So, for example, it's about XLH. For example, we go about how to improve growth, and the comparison, for example, is growth hormone or no growth hormone. We looked at the PubMed for all available studies. We had about more than 8,900 reference to check, and in the end, 196 references are cited in this guideline. We used, as I already said, the American Academy of Pediatrics grading system, which is quite nice, which has a 2-dimensional matrix. First is that we always check the evidence quality. The evidence quality would be A, that's the highest level. If there would be very many well-designed, conducted, randomized trials, which is of course not the case in XLH, you can skip this. But we have sometimes good trials with minor limitations. Sometimes we only ended up with expert opinions. And then after checking the evidence on the PICO questions, we'd have to check what about the benefit or harm. For example, you could have an extremely nice randomized trial, but the benefit of for the patient is quite little. So we usually would not say it's a strong recommendation. So well, it's highly evidenced, but I think the benefit patient is not high. So we end up with a weak recommendation. On the other hand, if we have one randomized trial with a clear benefit or harm, then we could say, well, it's a moderate recommendation. So, and to make it more easy for you to follow me, I used the symbols here to demonstrate always after the recommendation what is the evidence and what is the strength of the recommendation. So let's go to the recommendation. The first is about the diagnosis in children. So the diagnosis of XLH should be considered in the presence of clinical or radiological signs of rickets, impaired growth velocity, serum phosphate levels below age-related reference range, that's very important, associated with renal phosphate wasting in the absence of vitamin D or calcium deficiency. So everything is said in just one sentence. So when we do the diagnostic workup, we of course have to thoroughly assess the patients for clinical signs of rickets and growth failure. We have look for dental abnormalities, which may be even present in young children, and we have to look for important comorbidities like granulosynostosis or signs for intracranial hypertension, and we need to do a thorough orthopedic assessment. That does not mean that we send the patient to the orthopedic surgeon, that he starts immediately orthopedic surgery, but I think it's important to show the patient, present the patient to the orthopedic colleague that he get a feeling for the patient and that he also regularly follows the patient. And the decision for surgery should, of course, always be made together with the pediatrician, the family, and the orthopedic surgeon, if at all necessary. So radical evaluation is very important. We look for the abnormalities with respect to rickets, especially if there's an irregular physis, and we look for the bowing and other things. And then we come to the biochemical assessment. It's not much we need. It's rather cheap. You just need a serum phosphate, check what is the age and use the right normal reference values, check calcium, alkaline phosphatase, PTH, vitamin D level, so it's not, we exclude a vitamin D deficiency, check the 125 vitamin D. I will later on explain why it's important to measure it, because usually we don't use it so much in clinical practice. And of course, we have to check the renal function. And then it's very important, and also very cheap, we have to check in the urine calcium and phosphate and creatinine. We use a spot urine. We don't need a 24-hour urine. And you calculate only two things: the renal phosphate threshold concentration, TMP over GFR, which is more sensitive and more useful than the fractional phosphate excretion or the phosphate reabsorption. And then, very important, the calcium creatinine ratio to exclude hypercalciuria at the beginning. And as we nephrologists are very happy to do and always look for, we have to, of course, check that it's not in Fanconi syndrome by the measures we all know. So what is the typical constellation for the biochemical abnormalities? Low serum phosphate, high alkaline phosphatase, reduced TMP over GFR. Serum calcium is always normal. Urinary calcium is usually low. If it's almost at the upper normal range, then you have to do an alert, because then it's pointing to another disease. PTH levels are usually in the normal range, or only slightly elevated. And vitamin D levels are low, or let's say better, inappropriately normal in the setting of hypophosphatemia. And in untreated patients, for XLH diagnosis, intact FGF23 are usually elevated. Please keep in mind that the tests available have different reference values, and some of the tests have never been validated. So if you've done the molecular diagnosis, we recommend to confirming the diagnosis by analysis of the PEX gene. This is important, especially to exclude other rare diseases mimicking XLH. And the other thing, if you use new treatment modalities like burosumab, and the patient has not an XLH as an underlying disease, you may run in troubles. If the PEX gene is negative, then you have to, of course, check for other causes. And if the PEX gene is not available, we felt that to check for intact FGF23 and or a positive family history is helpful to establish or further support the diagnosis. So we present also in the guideline a nice algorithm how to come to the diagnosis. So we have a child presenting with rickets and low phosphate levels. And the most important thing first is, of course, to look for PTH. If PTH is markedly elevated, then it has nothing to do with XLH. Then it's one of the various forms of vitamin D deficiency or vitamin D receptor defects, and then we have a total differential diagnosis. If the PTH are normal or in the upper normal range or even only slightly elevated, then we check for urine levels of phosphate. If you have phosphaturia, despite low serum phosphate levels, then everything is pointing to various forms of renal phosphate wasting. If not, we have to look for rare causes like insufficient phosphate intake or short bowel syndrome or some milk formula there was some case report in the US, resulted in reduced phosphate reabsorption. So this is important to check. If you have elevated FGF23, then you come to the phosphate wasting forms, which are due hereditary. This also includes XLH, or you have maybe have acquired form, for example, a tumor producing FGF23. If they are normal or low, then you have two forms, especially the hereditary form of hypophosphatemic with hypercalciuria or Fanconi syndrome. In the guideline, we will see all the table with 26 differential diagnoses. I just want to point out 3. So if you have renal phosphate wasting, an elevated FGF23, and there are various diseases, including XLH, the autosomal dominant form follows an autosomal dominant trait, and the patients have usually milder form of the disease, and they usually present later with clinical symptoms. So if a patient fulfills this criteria, you have to check for autosomal dominant form. And then if the patient presents also after the 2nd year of life, you have to check also for tumor-induced osteomalacia. And if you have no elevated FGF23 and only tubular phosphate wasting, then 2 forms are very important. First form is a very rare form, which was originally reported in Bedouins in the Middle East, but is also present in, seen in European patients. This is due to mutations in the renal phosphate transporter, and these patients have also low TMP or GFR, but not elevated FGF3. But most important, they have high urinary calcium, and they usually have elevated 125. And you have a patient like this, you must not give them active vitamin D, and you must not give them, for example, burosumab. You have to be very carefully in the follow-up. And then, of course, you have to check for cystinosis, which is also, of course, just a tubular loss, and there's no increased FGF23, except the patient has advanced renal failure, for example, in cystinosis. So we present a nice table for follow-up, and for time reasons, I would just skip this. We have to check the patients for the clinical signs of rickets, of growth, check regularly for rare complications, which you can find in the guideline. And then I just would like to focus a little bit on the biochemical monitoring. You really only need a few items to check. You have to check regularly the alkaline phosphatase. It's markedly elevated depending on the degree of rickets because of the mineralization defect. You need to check calcium, which is usually not a problem. You check phosphate, although during regular phosphate substitution, it does not increase. You have to check creatinine as a measure of renal function to avoid renal failure. Very important, you have to check PTH, because if you give phosphate to the patients, you stimulate secondary hypothyroidism. And of course, you have to check for vitamin D. And very important, during the treatment, you have to check for urinary calcium creatinine ratio, which may increase, especially in patients receiving high dose of active vitamin D. So that's in all patients. And if a patient gets the new drug, the burosumab, it's worth to monitor fasting serum phosphate levels, because the goal of the treatment is to increase the reabsorption of phosphate and thereby increase or serum phosphate levels in the lower normal range. And we felt that it's worth to combine it with a TMP over GFR, because in the study it was quite obvious, or also in clinical practice, that if you start burosumab in the patient, that in the beginning the phosphate levels may not rise in the normal range, but TMP over GFR is already normalized, because all the phosphate just goes to the bone and the serum phosphate levels do not increase. So we felt it's quite worth as a clinician to check this as well regularly during the treatment. And of course, you have to check this if you adjust doses, and we felt it's worth to check as a safety parameter 125 in patients on burosumab. So having said this, we come to the treatment. So we recommend treating children with overt XLH phenotype. That means there are some patients who have almost no clinical symptoms despite XLH. They, of course, don't need treatment, so we call this overt. And we say that they should receive phosphorus. It's usually given as phosphate salts and active vitamin D. As soon as the diagnosis is established, the doses are usually for phosphate between 20 and 60 milligram per kilogram per day. Please remember, it's always based on elemental phosphorus. If you want to make it more easy, you just use the millimoles, then it's between 0.7 and 2. And you adjust the dose according to improvement in rickets and growth. And you use also alkaline phosphatase and PTH levels. Young patients, especially those with markedly elevated PTH, may need higher doses and more frequent application. If the patients have a milder phenotype or have an infant diagnosed by family screening, then they may need lower doses. With active vitamin D, there are two preparations. As you know, it's calcitriol and alpha-calcidiol. Please remember the bioavailability of alpha-calcidiol is about only 50% of that of calcitriol, so that a rule of thumb, you usually need the twofold dose of alpha-calcidiol to have the same clinical effect as for calcitriol. And if you don't want to calculate a nanogram per kilogram, you can also start in an older child above the age of 12 months just with empirically with 0.5 microgram and or 1 microgram. And of course, you have to check for calcitriol supplements. This I will skip. So when to start burosumab? As you know, burosumab is licensed in Europe in children aged above 1 year or older, and in adolescents with growing skeletal. So if the epiphyses are fused, then you are not allowed to prescribe it, at least in Europe. And EMA clearly says that they need to have radiographic evidence of overt bone disease. So there must be something on the radiographic picture. Without that, you are not allowed, at least in Europe, to prescribe it. So then we felt, well, the standard treatment is conventional treatment. Which patients may benefit most or should be considered to switch to the new treatment modality? And then there was uniformly a consensus that if the patients are refractory to conventional treatment, they should be considered. If they have complications, or this is especially important for adolescent patients, if the patients are unable to adhere to conventional therapy. But then we said, well, everyone can say I'm unable to adhere, I don't use it. But then they must show up in order to perform adequate monitoring for the burosumab treatment. So this we felt was quite consensus in the group, and this was also nicely confirmed by the Delphi process. So 2 minutes about the burosumab dosing, which is not tricky at all. And so the starting dose in Europe is 0.4 milligram per kilogram. In the clinical studies, the mean dosage for the whole group of the 56 patients was about 1 milligram per kilogram. But EMA was quite smart. They checked it and they noticed that some patients went quite well with a low dose of 0.4 milligram per kilogram. So the EMA said, well, we recommend the starting dose of 0.4 because some patients are extremely happy with this low dose. So we kept this in our recommendations. So the goal is to raise the fasting serum phosphate levels to within the lower end of the normal range for age, and with a maximum dose. This comes also from EMA. And the dose should not be adjusted more frequently than every 4 weeks. This is very important. From the pharmacokinetics, it's clear that a steady state, when using a constant dose, is assumed after 3 months. So if you start a patient and you check the phosphate levels and you're not happy and you increase, you never come into the steady state. So it's recommended to wait at least 4 weeks to consider increasing the dosage. So there's no need to hurry and to rush and to make the patients crazy that they show up and send faxes around with the phosphate levels, because everyone just gets crazy. So the next question is, from the pharmacokinetic point of view, we know that if you inject burosumab, you inject it every 2 weeks, I forgot to say, then after 7 to 11 days, there's the peak maximum of burosumab in the blood, and there's also the peak of the serum phosphate level. So in the beginning of the treatment, we don't want to check that we have under treatment. What is important in the end, we need to check hypophosphatemia. So if you want to be on a safe side and you want to avoid hypophosphatemia, and it's good to check the serum phosphate level between day 7 and 11, then it's clear that you don't have hypophosphatemia. And if you have a steady state, which I just said, it's after 3 months, then we rather want to check for underdosing than we check the levels just before injection. So this is not a must. You see here it's a B week, so it's high evidence because we know it from the pharmacokinetics, but it's not required by EMA. So we said it's wise to do, but it's not a must. So it's a B week, and we were quite happy to come to these conclusions. So, and then it's quite pretty forward. If the phosphate levels are elevated, you have to stop then, and you may restart then if we return below the normal range. And that's very important. Do not administer alongside conventional treatment. That means phosphate salts or active vitamin D. Native vitamin D is allowed to combine, but not active vitamin D. And then, of course, if there's renal impairment, you are not allowed. So one word about growth hormone. There's a bulk of evidence that growth hormone stimulates standardized height up to 3 years, also in randomized controlled trials. But unfortunately, the follow-up analysis for final height in at least our studies did not prove the hypothesis that growth hormone increase final height. So we said that retreatment is not recommended, but we may consider growth hormone provided good metabolic control, especially with respect to alkaline phosphatase and PTH in those patients, either on conventional or burosumab treatment. So just one word to the dental part. If you have time, please read the section on dental involvement, which is perfectly written by the specialists from dentistry. And they nicely wrote down what to look at and what interventions are required, and they especially made a nice list for the dentists who take care in the clinical practice locally, and you can hand over this publication just to your local dentist, and he just has to read this, and then he knows what he has to look for. That's very helpful, at least in my limited experience. The dentists were quite happy to have something in their hand. So the take-home messages is that you make the diagnosis of XLH based on the rickets, hypophosphatemia combined with phosphate wasting, but no disturbances in vitamin D deficiency, vitamin D metabolism. Whenever possible, it's good to confirm it by molecular genetic analysis or at least measurements of FGF23. We recommend that children with an overt phenotype should be treated with a combination of phosphate salts and active vitamin D. And I already explained, at least this was consensus in our group, which patients may benefit most on the new drug of burosumab. And if available, we recommend to use those indications to consider to switching patients. And having said this, I'm exactly in time and would like to end to announce the next webinar, which starts after the summertime on September 10. It's a very important topic for pediatricians. It's about pregnancy and CKD, and this will be done by Kathleen Klaas from Leuven, Belgium. With this, I would like to thank you for your attention. Hello?
Thank you so much, Dieter. Can you hear me?
Yeah, I can hear you.
Yes, so thank you so much for this very clear presentation, as usual, and this is very relevant for our practice, I think, and for the audience, please don't be shy and send me your questions and I will read them to Dieter. I have a question for you while waiting for the other questions. Do you think, or do you have experience of patients receiving growth hormone therapy and then receiving burosumab? Can we treat patients with the two drugs concomitantly or not?
So it's, first I have to say growth hormone is off-label use. So usually we have to apply for the health insurance company, but it's allowed to do this. And I personally treated patients who was already on growth hormone, and we just started her 1 year ago on burosumab, which went fine. But we don't know if growth hormone works better or less if you combine it with burosumab or not. We don't have data. I think this would be nice to check in the future registry.
Yes, I think it can be interesting because Fernando Santos in Spain has very nice data on concomitant therapy in his HYPE mice of growth hormone and burosumab on the growth plate. And in Lyon, we have one patient receiving both burosumab and growth hormone therapy, and maybe it could be a sub-study to evaluate in these specific patients. But I think for clinical practice, we can prescribe burosumab in patients already receiving growth hormone. Thanks, Dieter. I have another question for you. Can you hear me?
Justin, should we just do the three questions prepared as a warm-up for the people? So
yes, I will start the polls.
Yes. Yeah. So, okay. Okay. If you want, yes, okay.
So then I'm done with that. Thank you.
Okay, I was thinking that you. Okay, it was just after your presentation. Okay, so go back to the poll.
So I think you can see there's I think 3 questions. The first is which findings or finding does not fit to the diagnosis of XLH in the patients without prior treatment, and you can one or more than one of these questions could be right. I think we go one by one question, no?
Yes, correct. Now I will wait some time until more or less 80% have voted. Just one more few seconds. Okay, I think I will close the poll and show the results.
Okay, so low serum phosphate is of course, so the wrong ones are elevated PTH. If elevated PTH is present, then it's one form of vitamin D deficiency or vitamin D receptor defect. And of course, elevated urinary creatinine ratio, which is usually, it's always could be a Fanconi syndrome with cystinosis, which is also very easy to see, but more important, the hereditary form of hypophosphatemia with hypercalciuria. And then, of course, the same as the elevated 125 level. So we check the elevated at 125 level for one purpose, just to exclude the form with hypocalcemia. Okay, next question. So, which statements, so it's always tricky because it could be one or several right answers for the conventional treatment of pediatric XLH patients is or are true? So, which is true?
Okay, Dieter, I will close the poll.
Okay.
Know the results.
Okay. So the first is of course not true because conventional treatment usually includes phosphate and active vitamin D, and so this is I have to admit that this was a little bit misleading, but when you look closely, here stated phosphate salts, and then you see the dose, but you never ever do the dosages by calculating the phosphate salts, which markedly differs with the content of elemental phosphorus, but the dosage is always based on elemental phosphorus. So that's why this is not true. And conventional treatment does not increase PGO or CFR, it rather increases it. It decreases its story. And then this is right, the calciferol dose. And as I said, alpha-calcidiol, you usually use a little bit higher doses. Sorry about that with this formulation, but this was for me a very important point, which I have to admit just learned 30 years ago as a young physician because I did it wrong. And my senior consultant announced me that I was more practicing. So we go for the next one. So now we come to burosumab. Which statements for burosumab treatment are true? We also have 4 options, and one or more than one could be true.
Okay, again, I will close. Sure.
Okay. So this is not true because the fasting serum phosphate level could be kept in the lower normal range, not in the upper normal range. So TND over TFR is really recommended, so that's the most people did it right. And this is clear that active vitamin D must not be given. At this stage, the EMA and FDA clearly announced that in a patient receiving burosumab, you must not give active vitamin D because the authorities were afraid that the patients may get nephrocalcinosis. We will see the next coming years if this will change because we noticed that many patients had long-standing conventional treatment. They have rather a form of secondary or rather tertiary hypothyroidism, and some of them maybe don't run nicely when using burosumab alone. But at this stage, you must not give it. And the starting dose in the US is 0.8, but this, since ERKNet is European, this is not right, because we go for the EMA prescription, which is 0.4. So nevertheless, most of the people made extremely nice and crossed the right boxes. So thank you very much for that. Maybe now more questions.
Okay, so thank you. Yes, I have at least 4 questions, but if other people want to ask, don't be shy and send me your questions. So first question is, thank you for your talk. I just want to know your opinion about conventional therapies with skeletal problems, but what about other effects of FGF23 with conventional therapies?
I don't know if I understand the question right. So in the patients on conventional treatment, we never measure FGF23 because it's sky high. We know that because phosphate and calcium stimulates it. And we, of course, have to check for all rare or common comorbidities associated with XLH patients, including, for example, craniosynostosis and everything else. So, so the topic FGF23 is not addressed, but we look for rare complications. I hope that I got your question right.
Yes. So the second question is, what is the mechanism of action of burosumab?
So the effect is quite easy. It's an antibody. It is injected subcutaneously. It goes to the blood, and wherever it is in the body, it binds FGF23. So, and if FGF23 is bound to the antibody, it cannot bind to the FGF receptor. So in the end, it inactivates FGF23. And if it stays in the blood for many weeks, but we know from clinical practice to have a good clinical response, at least in children, we need 2 weekly applications. And in adults, you know that the FDA also approved the use of burosumab in adult patients, then it's fine to give it just every 4 weeks.
Okay, so we have another question, is how do you define the resistance to conventional therapy? Is it a lack of resolution on X-rays, or is it an abnormal serum phosphate level?
So the normalization of serum phosphate level is not a goal on conventional treatment. So there may be some patients who get normalized phosphate levels, but it's very rarely. So the response to conventional treatment is not based on normalization of serum phosphate level, but it's based on the clinical and biochemical normalization of rickets, which is on X-ray, on bowing, pain, and biochemically, basically normalization or almost normalization of the alkaline phosphatase. And this together is the clinical response. I hope that it's okay.
Okay, thank you. Yeah. We have another question, so it's maybe more a comment than a question. In poor income countries, burosumab is not available, neither FGF23, and we just treat patients with phosphate and vitamin D with good outcomes without growth hormone. Is that good?
Absolutely.
So I think it's
absolutely
more than a comment.
One important point is that I think the therapeutic standards change with improvement of diagnostic tools, but just using the biochemical parameters available in your country and checking urinary calcium creatinine ratio and 125 levels and PTH at the beginning, together with the pedigree of the patients, allows a clear diagnosis in the majority of patients. So I think that's fine. But if you have, in addition, the measurement of FGF23 available, then go for it. If you have a negative family history, if you don't have available, well, that's it. So, but the genetics, I especially point out for patients who get started on burosumab, just to exclude that they don't have any other funny diagnosis. And when you look at the tables in the guidelines, most of the parameters shown there, they're already available in every country. So by use of that, just checking the boxes, is it a Methuen Albright, are there other abnormalities? I think most of the patients can be nicely diagnosed as well. So it's fine.
Okay, thank you. We have another question. I think it's more for the conventional therapy. Should we routinely monitor urinary calcium over creatinine ratio?
Absolutely. I do it every 3 months, and I think in the guideline you have to check. It's I think every 6 months or so. It's very important because you know, one side effect is nephrocalcinosis, and there are patients who have a normal urinary calcium creatinine ratio, and they get nephrocalcinosis, but as a rule of thumb, elevated urinary calcium creatinine ratio is associated with nephrocalcinosis, and patients presenting with hypercalciuria, you should check if you could reduce the dose of active vitamin D. So it's very important. And it's cheap.
Okay, we have two other questions. Yeah.
Yeah.
Yes, sorry, Dieter. We have two other questions. You presented data on incidence and prevalence of XLH on your first slide, and from which country were they from?
I think they are probably from Europe. I think most of it. They are not from Asia, and I think they are from Europe and from North America. Usually the data, and yeah. But of course, the prevalence may differ in certain countries. And please remember, for example, the hypophosphatemic rickets with hypercalciuria is very prevalent, for example, in the Middle East. So there may be differences.
Okay, I hope this answers the question. And the last question I had at the moment is if you said that we may have a normal TMP over GFR and hypophosphatemia, and that would reflect the phosphate that goes into bone. And the question is, if a patient receives burosumab, should we re-inject burosumab when TMP over GFR begins to decrease rather than on phosphate levels?
I think you have, you know, burosumab, it's a new treatment modality. And if I give you a recommendation, to be honest, I don't have experience for 10 years with many patients. So and based on my personal experience in a few patients and all the studies available. So what we do, we use the composite of the serum phosphate level, having in mind the time to the injection, and having in mind the TMP over GFR. So in my experience, the treatment with burosumab is really very effective. And even if you use only the starting dose, the patients are all, I think they are better doing than on conventional treatment. So there's no reason to increase the dosage quite often. Just start with a low dose, check if the phosphate goes into lower normal range. If not, then you check the next time. If the TMP over GFR is almost normal, then you are on the safe side. So use the two together and make, like always in medicine, it's the art of the physician to treat the patients, have both things together and to get a feeling for that. And of course, you know, TMP over GFR is a little bit variable, and the serum phosphate level will vary, especially with the time point after the last injection. Please keep this in mind, because sometimes I get phone calls from physicians who say, well, now the phosphate is decreased. The last time it was very fine. And then I said, well, when did you check the blood? So, oh, I don't know. So please have this in mind, that it really heavily depends on the time point after the last injection when you assess the serum phosphate level. This may differ markedly. It's just pure pharmacokinetics.
Okay, so thank you, Dieter. It was very clear. I think you have answered all the questions. So thank you so much for this presentation. And please do not forget the next webinar in September on pregnancy in CKD. Thank you so much, all of you, for being there today, and enjoy your summertime. Bye-bye.
Thank you very much. Bye-bye.